Good afternoon. We can hear the helicopter in the background. This is Dong Kim, and I am going to talk in today's webinar about brain or cerebral aneurysms, or also called intracranial aneurysm. And you may have this condition, or you may have many families that are affected with this, because it does run in families. And so we'll talk about what aneurysms are, how we find them, and what we do to treat them. So this is the outline. So this is a schematic of a blood vessel. And our blood vessels in the brain have several characteristics that are important. First, if you look at the green arrow, unlike in other areas of our body, let's say the arm, our arteries in the brain flowed in very clear fluid called cerebral spinal fluid, which is on the outside. So what that means is that there is not an external support for the artery like exists in some other areas of the body. Also, like all arteries, there are branch points, like where the arrow is now. And what happens is every time our heart beats, there's a pulse of pressure that comes up, and this pulse hits a branch point or a curve before going on its way. So certain areas like here get a lot of stress during our lives. We call that hemodynamic stress. And some of us, for various reasons, if this area is weaker than it should be because of genetics, or it's been injured by cigarette smoking, or maybe it's thinner than it should be because we're women, this area can bulge out, like you see in the next picture. And as soon as it does that, it's an aneurysm by definition. Over time, this aneurysm can grow, like in this schematic. And as you can imagine, once the aneurysm is larger, more and more blood comes up and hits the walls. Just like a balloon that's blowing up, the walls can get thinner as it gets larger, and then it becomes at risk for rupturing or causing bleeding. Because it's an artery that's bleeding and it's around the brain, this can be a very serious condition when it happens. So this is a picture I like to show, and it's a sketch done by one of the very first neurosurgeons and a giant named Walter Dandy. And he was one of the first to write a book about aneurysms, which I happen to have a copy of. It was published in 1944. And in it, Dr. Dandy has drawn a schematic of what you might see in surgery. You can see the patient's skull in outline. The eye is over here. And coming into this area of the brain is a normal carotid artery, which you can see on the patient's left here. On the patient's right, you can see this aneurysm that's bulging out. In this case here, and can occur with other kinds of aneurysms, the aneurysm is now pressing on this nerve. This nerve happens to be the optic nerve, the nerve that we see with. And you can see the normal configuration on the left, which is straight, and the carotid artery sits right next to it. But on the right, the aneurysm is now pressing on this nerve, and this patient might develop vision loss. Pretty picture. He clearly was a very good artist. And in the next photograph, I'm going to show you an aneurysm in that region. This is a picture from surgery. It's a little disorienting when you see it like this, but part of the brain is here. That's called the frontal lobe of the brain, which we move out of the way. Part of the brain is here. This is called the temporal lobe. And this is the nerve I was showing you before, coming from the eye, called the optic nerve. All of this is the aneurysm and abnormal. What we should really see is the carotid artery, which is here and long and tubular, and this whole mass should not be here. This patient also presented with a little vision loss because of the pressure here, and this aneurysm was discovered. So that's what an aneurysm is. The best way we can see an aneurysm is from a test called an arteriogram, or another word for it is an angiogram. And if you have had it, these are studies that are done with a needle into the groin, and then a catheter is passed into your arteries. It's very similar to a cardiac catheterization or a heart angiogram, except this is done for the brain vessels of the blood vessels of the brain. And in this procedure, dye is directly inserted, it flows into the arteries, flows into the aneurysm, and then can be visualized the best. This is what we call the gold standard study, but it's invasive, and because it involves injections and catheters, there is a small but real risk of a complication. And they are still useful in certain situations, but nowadays we can see them on other studies as well. And this is an aneurysm that you can see on a MRI scan. It's this bubble here. You can see the location right here. This is on two different images. There is a special type of MR or a CT which is designed just to look at blood vessels, and they're called MRA or CTA. You may have had one of those studies. That stands for MR angiogram and CT angiogram. And in that, it's these same images, but the computer just removes all the other anatomy, and it just looks like the blood vessels. It looks like an angiogram, but there is not any dye or catheters put in. And it's a very good study, and many times that's the only study we need, but sometimes we do need to do a formal angiogram to decide what we need to do for the patient. So how do aneurysms present? Well, of course, the thing that we worry about the most is a brain hemorrhage. And I don't expect any of you watching this to have just suffered a brain hemorrhage or will have a brain hemorrhage soon. It's not a common event. Some of you who have had treatment already may have had this, but the presentation is going to focus on patients who have unruptured or aneurysms who have not suffered a hemorrhage, because those are the patients that will be referred to clinic, that may be looking for a doctor, that may have decided what to do. If you have a hemorrhage, it's an emergency, so you got to get to the hospital right away. And a brain hemorrhage from an aneurysm is very stereotypical. It is an incredibly abrupt headache. It happens right now, and a patient will be able to tell me it happened at 3:07 p.m. It didn't just kind of gradually come on, or next thing I knew I had a headache. It's also not like any headache you've ever had in your life. It's what we call the worst headache of my life. It's constant. It usually lasts for days, if not weeks, and it's accompanied by neck stiffness, sensitivity to light, and then maybe even sleepiness. So I don't want people in the audience with aneurysms to worry every time they have a headache that something bad is happening. When you have a brain hemorrhage, you will know, and it's some of these things. And we're not going to talk about what to do in that situation, except call 911 or have somebody take you to the emergency room. You don't want to drive yourself. What we will talk about is how unruptured aneurysms are found and what we need to do about them. So how do unruptured aneurysms present? Well, the majority of the patients I see now, it was found because somebody ordered an MRI or a CT scan for a whole different reason. You developed vertigo, and your doctor wanted to make sure there's no tumor. You had a car accident, and they wanted to make sure there was no brain injury. So an MRI or a CT scan is done. Oh, they see an aneurysm. Then they might do a second study, which usually is an MRA or a CTA. It's confirmed, and they say, go see a neurosurgeon. Probably 3/4 of patients I see in clinic are picked up for this way. They had a small stroke and they're in the hospital. There are lots of reasons. The other 1/4 of patients actually had some symptoms that emanated from the aneurysm, but they are not symptoms from the hemorrhage. An unruptured aneurysm in uncommon cases, not rare but not common, can cause headaches. And they can cause headaches when the aneurysm gets really large or when they're in specific locations where they're near sensitive pain fibers, and when the aneurysm grows, it can press on a membrane that has pain receptors on them. So this headache is different. It's gradual. You may or may not even notice it at first, but over time, it starts to become worse, and more commonly, it becomes constant. It's there all the time. It's there every day. And one general thing that we can say about headaches is that new headaches that are slowly progressive and become constant are headaches that need a doctor's evaluation and that you need to get an MRI scan. They can be from tumors and other things, but that is not normal. Those of you who've suffered headaches your whole life, or the kind of headache syndromes that we do know about, like migraines or cluster headaches, those headaches are episodic. They come and they go. They are not there every day. So this is one of the things that we think about when we hear a headache story. If you've been having headaches that come and go since you were a young adult, that's one thing. But if you're 45 years old, you've never really had many headaches in the past, and over the last 3 to 4 months, you seem to notice this headache that's getting more and more common. Even if it's not severe, that is something different. Finally, there are some patients that have a problem, just like I showed you in that example. Your vision isn't as good in one eye as you expected, or you're having double vision, or your one eyelid looks droopy. These are all nerve problems that can happen because an aneurysm is pressing on it. So those are the main ways we present. Here is an example. This is a 44-year-old woman who over about 6 months, and it happened so gradually she hardly noticed, started having very subtle headaches that got a little bit worse. It was not even severe when I saw her. She could take an Advil or Tylenol and it would go away, but it would be there pretty much every morning when she woke up. And then more recently, she started feeling like her vision in her left eye just wasn't that good. I was going to go see the eye doctor. But she could also say that when she covered her left eye, her right eye seemed fine. It was just in one eye. And if you look at this MRI, which is another example of an aneurysm, this is what we call a coronal view, which shows the top of the head here. One ear would be here, one ear would be here, and the two eyes would be in the front. This is her aneurysm. It's quite large, and the size is causing the headaches. And you can see these is her vision nerves, and the one on the left is being pushed up and is quite higher than the one on the right. It's that pressure that's causing her vision problem. This is just another view where you see the two eyes and the top of the aneurysm. So the MRI made the diagnosis in this case. So how common are them and who gets them? It's something that clearly increases as we grow older. So we don't see many children and young adults with them, so we don't generally worry about it in this population. Even in the general population, it is not considered to be that common. And for a long time, we thought for an average middle-aged person, it would affect 1 or 2% of people. It may be a little more prevalent than that, and then as we grow older, the incidence increases. And if we looked at a lot of 80-year-olds, it may be much higher, the percentage of patients with an aneurysm. The important thing to know is that many people can have a small aneurysm their whole life and die of a heart attack when they're 90 and it never bothers them. And so when we look at autopsy studies of patients who have died for different reasons late in life, we do see a lot of little aneurysms, but that was not the cause of death. So one of the things we're going to be talking about is how do we know who needs to be treated and how do we know who's at risk. Just having an aneurysm does not automatically mean you need to go and get it repaired. The strongest risk factor we have is a family history. And if we took 140-year-olds off the street, just random, and did MRAs on every one of them, we would find it probably in only one person. And for that reason, we don't do screening. If we took 100 people with one first-degree relative, and by that we mean somebody who's pretty close to you, a grandfather, a father, a sibling, or even a child, then that risk goes up. And maybe we'll find it in 5 people. If we took 100 people who had 2 immediate family members who were affected, we would find it somewhere between 10 and 20 people, maybe not right at 40, but over their lifetime. So you can see that the risk goes up significantly based on your family history. In fact, my research for a long time has been on finding genetic issues and finding genes involved. I think we have had a pretty interesting and important discovery recently, which we're going to be publishing soon, but there is no question that there is a genetic factor. Now, if you are in such a family, let's say you're hearing this webinar for the first time, or you're listening to it because your mother had it, and it turns out your grandmother had it and your aunt has it, then we do recommend screening for patients in those families. We do not start screening until age about 25 or 30 because we don't find it before then. This is something that develops during our life. But if you're in such a family, then you should get an MRA, that's what we recommend, and you only need to get that every 5 years. You should also remember that even if you are in such a family, the majority of family members, at least 80% and maybe 90%, will never develop an aneurysm. So you don't have to worry about it, but I think that's enough of a risk to do a screening. The other 2 strong risk factors we know of is smoking, and the last one being a woman. There's nothing you can do about that if you are a woman, but we clearly find more aneurysms in women than men, although it is not rare in men. Okay, so let's say we found an aneurysm. The big question is, what is the risk of rupture? And this is something you're going to have to talk to your doctor about. The biggest factor that we know of that affects risk is the size of the aneurysm. And as we talked about before, the larger the aneurysm gets, the thinner the walls can be and the more we worry about it. So if you have a 1 or 2 millimeter aneurysm, we would call that low risk. If you have a 20 millimeter aneurysm, the largest aneurysm I've ever treated was probably about 50 millimeters, so they can get quite big, then the risk of rupture is quite high. Some locations, particularly in what we call the posterior circulation, there's 2 major types of arteries that go to our brain, the anterior and posterior, seem to have a higher risk. For surgeons that treat a lot of aneurysms, there are also some anatomical characteristics that worry us. If the aneurysm looks really irregular, or if the aneurysm has a little bleb sticking out of it that we call a daughter. So those are all things that we think about of the aneurysm itself. And then, of course, the risk also depends on the patient, you. You know, if you're 85 years old when we find the aneurysm, your risk in terms of how long you have to go worrying about the aneurysm is much lower than if you're 30 years old. What is your general health? So these are very important characteristics for us to think about. So then we should get to who needs treatment. Well, in general, if you're having symptoms, you probably need treatment. First of all, you know, headaches, who needs to have headaches every day? If you have a deficit like double vision, that's something that can get worse as the aneurysm grows larger and you certainly want to fix. And generally, when you are having symptoms, the aneurysms are large enough for us to want to treat anyway. It's almost, well, I would not say almost, it's probably never that a 2 millimeter aneurysm causes symptoms in a patient outside of if it hemorrhages. So symptomatic patients go in one group. Now let's say you have an incidentally found aneurysm. That's where we need to sit down and look at all those characteristics that we talked about. Where is the aneurysm? What size? How big? What does it look like? And weigh with your doctor the risk and benefit and decide what to do. And the reason for that is that there is no procedure that we have that has no risk. And if the risk of the procedure, which at a minimum is about 5% of complications and can increase depending on the location and size of the aneurysm, if that risk is higher than the risk of doing nothing or just watching it, then it doesn't make much sense, rational sense, to go ahead and put you through a procedure. So here are our treatment options. Let's say you come to see me or your neurosurgeon and there's a 3-millimeter aneurysm in the anterior circulation and it looks perfectly round and it was found by accident and you're 45 or 50 years old and you're doing great. I think it's very reasonable in that instance to say we're just going to do follow-up. For me, I do my first follow-up 6 months just to make sure nothing is changing quickly. And if that's stable, do it at a year. Okay, if you do the follow-up route, you have to follow up. You can't forget to keep getting angiograms. And if it changes, then it gives us a chance to say we're going to do something then. Okay, we found this in a 20-year-old, which we do occasionally, our thinking might be different. We might say, well, a 20-year-old has a long time to go, and maybe, we might as well go ahead and fix it. If we found it in an 80-year-old, that might be different too. So that's kind of how we look at it. The other option is to repair it now. And then if we do it, there are two different methods. And we call one clipping, and we call one coiling. And I'm going to describe those to you, and then I'm going to go through kind of how I think through this with the patient as we make a decision. So here's a schematic of the two options. In clipping, and I'm going to show you examples of both, the aneurysm itself is directly exposed in surgery. You directly visualize the blood vessels that are there. So it's an operation. And then you put a clip from the outside. This clip opens and closes. And then you place it at the neck so it pinches off access to it. And then no more blood can go into the aneurysm. The best thing about the clipping is that there's virtually no aneurysm we can't clip. And it closes the neck of the aneurysm so that no more blood can go into it. The worst thing about the clipping is that it's an open operation. We have to make an incision in your scalp somewhere. We have to remove some of your bone, and then we have to directly expose the aneurysm. The other treatment choice is what we call coiling. In coiling, we put a catheter, again through your groin, into an artery, all the way up into your aneurysm. And through the catheter, we put out these little coils that fill the inside of their aneurysm. And then you're reinforcing the wall, and if you get enough coils, the aneurysm will clot off inside, what we call thrombose, and then that will be protective as well. The best thing about the coiling is you don't need an open operation. This is still surgery, but it's a minimally invasive surgery done through your groin. But the worst thing about the coiling is that the opening to the aneurysm still exists, and blood keeps pounding on the coils, and the coils can compact in, kind of like filling a trash can with continuous pressure, and we do need to do more follow-up, and sometimes patients need a second treatment. So those are the two main types of treatment. This is an example of the different kind of clips that exist. They'll come on all different shapes and sizes. There could be a hole for a branch to go through, like in the other picture, and we can size the clips exactly to the aneurysm shape. These are an example of the coils. This part they're called detachable coils. It can be strung into a perfectly long string that goes through a catheter. Once the whole coil's in the aneurysm, then you give a little electricity, that coil detaches, and then the catheter can be removed. This is an old picture. Nowadays we have many different kinds of coils and all different kinds of shapes and sizes that makes this a very effective treatment too. So here are examples of two patients that were treated by clips and coils. This is a smaller aneurysm here that were filled with coils that you can see here. This is a larger aneurysm, and you can see the clip that goes on, and you've got to clip it so that it preserves the flow to the normal arteries, but the aneurysm doesn't get blood anymore, and the same thing here. You can see the normal flow. Because one of the risks that we do worry about the repair is having a stroke, since we are working on blood vessels. And that's something that is the main complication that we try to avoid. Okay, so here's the surgery advantages. We can get rid of more aneurysms completely through surgery because there's no more blood going into the neck. The recurrence rate is lower, it's not zero. There are very few aneurysms that can't be clipped, and the other advantage is that once the clip goes on, then the pressure on the mass of the aneurysm can go away right away. So if you are having, say, double vision, the best chance for the double vision to go away quickly is through the surgery. The disadvantages are that it's much more invasive than the coiling. There are some locations that are much higher risk or very difficult for us as surgeons to access, and we don't want to do clipping repair in those regions. And there's no question that the hospital stay is longer and the recovery is longer, probably on the order of 2 days in the hospital for me, maybe 3 with a open repair, and 3 to 4 weeks before the patient's feeling pretty good and ready to go back to work. This is a picture of a clipping done way back when. This was done by Dr. Dandy, again from that original book. It's a little different now, but some of the things I want you to think about, this is in a different location, but for all of these surgeries, the incision is done behind the hairline, so cosmetically there are no scars that are visible. We go through the bone, and expose the brain. The blood vessels and aneurysms are all on the surface or outside the brain. So we may have to retract it a little bit to see, but we don't go through normal brain tissue to repair it. And if the repair is done right, there should be no brain injury or deficits or any problems like that. Nowadays, the mortality from this operation is virtually zero. It should be zero. And, in the last 10 years, I can't recall a single patient that I've treated for this with an unruptured aneurysm that has died. So very safe nowadays. This is a photo from an actual operation, and you're going to see a video soon. But just to orient you, this is the scalp that's moved out of the way, a little bit out of the focus. This is the bony opening that we had. This is the frontal lobe of the brain, the temporal lobe of the brain. You can see all the blood vessels on the brain, and this is an aneurysm right here. Special features of this aneurysm are atheroma or atherosclerosis. These are cholesterol deposits that we sometimes see, which can make the repair much more complicated. And this is a vein that's draped across the top of the aneurysm, which was stuck to the aneurysm. I had tried to remove some of that vein, and it didn't want to move easily. And it's a vein that I want to preserve, if at all possible, because it's a normal vein, and not sacrifice it. So here's a more zoomed up picture of that. This is the brain. This is the aneurysm. There's 2 branches that you can't quite see well yet, but you will see during the video. This is one branch. The other branch comes across like this, and here's the tail end of it. The source of the aneurysm comes up here, the branch, and so because the blood wants to go straight, it was hitting this point as it was being diverted to the 2 branches, and then this bubble formed. And my job in surgery is to repair this bubble, but leave the good flow to the 2 branches. So we're going to go next to the video, and I'll be describing what we're seeing. Go ahead and start it. Okay, so that's a sucker on my left, and that's a little micro forceps, and I'm looking at a clip, and I don't really like this clip. it doesn't quite fit. You can see here that I put the clip between the vein and the aneurysm. I can move the vein out of the way, so even though it's stuck up here, now you can see the other branch. That's just a little dissector. I'm putting some water in it, irrigation, to keep it cool, and I'm putting a second clip. Now this has a hole in it, and I'm putting that hole around the cholesterol deposit. Because if I squeeze the cholesterol deposit shut, debris might go off into the arteries and cause a stroke. So the first thing I'm doing is putting a clip with a fenestration around the yellow part. You can see that. So the bottom here, where there's no cholesterol, is fixed. Now I'm taking a Doppler to make sure there's good flow into my arteries. I've kept that clip outside the vein. And then now I'm going to put a second clip that is now past the cholesterol deposit to pinch off the rest of this right here. And then with that, the aneurysm will be fixed. Here's a clip without a hole. It's a straight clip. And now I'm positioning it. Now first it looks like it's going to pinch the vein. So I'm moving it out of the way. And then now it's going to go and just pinch the aneurysm. And when it comes down, now this whole aneurysm, now this is the part we worry about the most. See how red that dome is? That's where it bleeds. And now I can see that the aneurysm's gone, but the normal blood vessels are normal. And that's the end of the video, but what we will do is then take a Doppler. Doppler's a little device where you can actually hear, where we can hear the flow of the blood vessel. So by the sound of the Doppler, I can tell that I have not pinched off the normal blood vessels. And that's what an aneurysm repair looks like in surgery. Now here's the other procedure. This is coiling that we talked about. The main advantage is that it is less invasive. We don't have to do the bony opening or an incision at all. It's all done through a little needle in the groin. It's a shorter hospital stay and recovery. When we do a coiling, it's 1 or 2 days in the hospital. And generally within a week, the patient is ready to go back to work. So much shorter. And this procedure, or this endovascular approach is what we call it, which means it's done from inside the blood vessel, is rapidly advancing. So we're getting more and more new things and new technologies. So this is going to be an increasingly important field. The disadvantages currently is that we can't completely get rid of the aneurysm quite as often as with surgery. And to be completely protective of bleeding, we know that we have to obliterate the aneurysm. There are some aneurysms what we look at, and we just cannot do the coiling because of anatomy. The main thing is if the opening or the neck is really wide, that makes it difficult because then the coils may come out into the blood vessel, and then it becomes a problem. In such cases, we sometimes have to put a stent in. I think you're all familiar with a stent, and that adds complexity and the need for medication. So there are some aneurysms we don't want to coil. There are some we want to do by clip, some we want to do by coil. It also has an increased rate of recurrence, and I showed you the reason earlier, because the mouth of the aneurysm is still often. And because of that, the protocol usually is to do another angiogram, a full angiogram, not an MR or CT angiogram, at 6 months, 12 months, and 18 months. If after 18 months, there's nothing different, and the coils look the same, then you don't have to keep doing follow-up. But there's a certain percentage of patients that will need another treatment sometime in that period. The other thing is if you have double vision or a nerve problem, then by putting the coils in, we're not taking away the pressure. And if the aneurysm clots, sometimes the aneurysm actually enlarges a little bit, so that deficit could get worse or stay the same. But over a few months, often the aneurysm does get smaller, and that could improve. So that's another factor for us to think about. So here's an example of a type of aneurysm that we like to use coils on. This is a artery called the basilar artery. And again, you can see that the basilar artery ends up in what looks like tree branches. Going to the left, there's 2 branches here, 2 right. Right where my arrow is should be nothing. Everything above is the aneurysm. The blood wants to go straight it weakened this wall and formed this aneurysm. This part of the aneurysm is called the neck, and the neck is pretty narrow, so this is a good candidate for filling it with coils. If the aneurysm looked like this, it's always harder to put the coils in. And this is just a side view of the same thing. So here's how the procedure goes. It's done in the angiography suite. It's done with x-rays and dyes. The catheter is already up. The catheter goes from the groin through what's called the aorta into this artery, which is a vertebral artery. You can see the shadow of the catheter right here, looks dark, comes into the basilar artery, and the catheter actually goes partially into the aneurysm itself. And then through the catheter, you can see here we're starting to put the coils through. This is just the beginning. Very little of the aneurysm is filled. You can see there's a lot of dye starting to get into it too. And then this is a video of it, and you can we can't see much, but over time, we're slowly advancing the catheter, and you're going to see more and more of this fill up slowly. Okay, and this is being x-rayed as we go, so as we're doing it, we can see it. Then when you're all done, you can see that now the artery comes up, and it looks normal. You can see an outline of all the coils in there. It's faint, but it's not filling with blood. You can see how well packed this is. And therefore, this area, which is usually where it bleeds from up top, is no longer at risk after the treatment. So we're almost at the end, and I'm going to spend a little time with this. So in summary, if you have symptoms that are emanating from the aneurysm, we generally will treat you. And the treatment will depend on a lot of things which you have to sit down with your surgeon and decide. Should it be clipped? Should it be coiled? Where is the aneurysm? What size is it? What does it look like? Who are you? How safe are you to have surgery? All of those kind of questions. Now, if it's not symptomatic, then it becomes more complicated. We look at all of the same things, but the first thing is to say, should this aneurysm be repaired or not? And many times the answer is, the best course of action is not to repair it. And I often make that recommendation. I can tell you there is one instance where even though that's what I think we should do, we end up repairing the aneurysm, and that's the psychological state and the preference of the patient. And that can go in both directions. There are some patients that are so scared of this, so concerned about the thought that they're going to have a hemorrhage when they're not expecting it, that they just can't live with the idea that there's this aneurysm. You know, and I have had patients like that, and they can't sleep well, and for those patients, it's often necessary to just go ahead and treat it for them. That can go in the other direction. There are some patients where, you know, I think the aneurysm should be treated, but they just don't want to have the procedure. It scares them too, and they know what the risk is, and they're an adult, and they're competent, and they can decide they don't want to do anything. If we do the watch and follow route, the main thing I want to reiterate is that you need to really watch it and not forget about it. And you'd be surprised how people do. And so if you follow it carefully, it can be managed safely. And I've also have lots of patients, probably on the order of hundreds, that I'm following out in the community, that we decided at certain times to only do follow-up. Now with my office, the way we do it is we don't just tell the patient, but we have a database. And every year when the time comes up, we send them a reminder. They get an MRA, we review it, and if it's stable and still small, we don't have to do anything till the next year. And then we just keep that schedule. A certain percentage of patients, pretty small, will notice a change, and then that's when we go ahead and treat it. Knock on wood, I am also happy to say that of all the patients that I am following, I've not had anybody have a hemorrhage out there while we're following them. So when the risk is low, it's low, and it's something that can be done safely. If a repair is needed, the main point I want to make for you is that you need to be at a center where both surgery and clipping is done well, and coiling and endovascular approaches are done well. And the best centers look at every aneurysm together with the people doing them, because they are different skill sets. And the person who is good at one usually is not just not good at the other, but cannot do the other. There are some people that do both, but because they're not the same thing, they're different skill sets, you need people who are expert at both. And you want to be at a place where you're going to get the best technique for you to have the best outcomes. And one of the things that I don't like, we have a lot of good physicians all over the country, but I don't like centers where, every patient gets one or the other, because that's what the expertise is. And if it's an emergency situation and you're in a rural area and this is the only thing available to you, obviously that's different. But if you're in an elective situation like this, you're thinking about what you want to do, you need to be at a center where there are real experts in both. The last thing I want to say is that don't be too scared if you hear the word brain aneurysm or cerebral aneurysm. A lot of patients come to my office terrified. When they were discovered, it was either by accident or for very mild symptoms. We have all kinds of great treatments for this. This is not cancer. This is something where patients do very, very well nowadays. So I think you can rest assured, make the right judgment. It can be for no treatment and observation. It could be for clipping or coiling. It's a lot of options to think about, but the outcome should be very, very good. So that's the end of my presentation, and we have questions that are already on the file. So I think we're going to have time for a few of them, and we'll look at it, and I'll start answering some of them. If you want, then go ahead and put in your questions now. Okay, the first question is, and I'll send that for everybody to see, is from a 54-year-old woman who had a sister that had an aneurysm about 15 years ago. What would be my risk and what would be my daughter or granddaughter's risk? I would say that the way we see it is that we call a family history when there are two or more immediate relatives that are affected. Most people do not have such a family history. And if you have one person in your family, that's generally not enough for us to recommend screening. So I don't think that this is something to be of concern, significant concern. Obviously, if you have another person in your family that is affected, then we would recommend screening for anybody over about age 25 or 30. One of the things you can do is talk to your relatives, especially your mother, and is there any grandparents that might have had it and so on, and you can get a family history. Okay, the next question is a ruptured aneurysm the same thing as a hemorrhagic stroke? The answer is that all ruptured aneurysms are hemorrhagic strokes, but not all hemorrhagic strokes are ruptured aneurysms. So hemorrhagic stroke is a broader category. The word stroke, we tend to think of a stroke as somebody who has like a cholesterol deposit or a blood clot and part of the brain dies. But in real medical parlance, the word stroke is anything that happens really suddenly, like a tennis stroke. And so a hemorrhage happens suddenly. You're going along, and then you can have a brain hemorrhage. So when you have that, it's called a hemorrhagic stroke. A hemorrhage can occur from a lot of things, of which an aneurysm is one. Okay, so all aneurysms are hemorrhagic strokes, but there are other hemorrhagic strokes. Here's another question. Once an aneurysm has ruptured, what can be done? Well, a lot. First, there are things that we can do to support the patient. There are things that happen as a result of the hemorrhage that we have to treat. Once an aneurysm has ruptured, it's at risk for rupturing again. So an early focus is repairing the aneurysm so it can't hemorrhage again. and then we've got lots of things that we do to help the patient recover from the hemorrhage. A hemorrhage can be anything from a mild hemorrhage to a very severe one, and the results of the hemorrhage are not nearly like repairing the aneurysm before the hemorrhage. So this is one situation where we can find a problem beforehand and repair it, and so that's the best thing. Here's another question. I had 5 aneurysms in August 2011 and had 3 removed, but still have 2 on each side. My 16-year-old son has migraines. Pediatric neurologist in Sugar Land. I am concerned about the need to get, okay. So first of all, I think having 5 aneurysms is very unusual for this person that wrote in. And we do know that affected families have more aneurysms. There are other things that cause aneurysms too, so I think if you're a young person with 5 aneurysms, I think there are other things we should think about, which is probably a little bit beyond the scope of this webinar. I don't think having a migraine headache has much to do with having aneurysms. And if it is migraines and your son has similar migraines that you've had, I do not think that means that he has aneurysms. I think the first thing to do is think about whether you have any other reason to have blood vessel problems. There are some other genetic conditions and even other conditions that can lead to multiple aneurysms. Once we have a clear reason why I think you have so many aneurysms, then that would give us more information on how to think about your son. So that's how I would answer that question. Here's another question. This was from somebody saying that the video, the coiling, went away. I think if you see it again later, you will probably see it for some reason, because we did see it here. Okay, here's another question. I am a 27-year-old female who just had 2 aneurysms clipped after a small rupture. How often should I get CTA scans to monitor in the future? Well, that's a good question. You know, for my patients, I tend to do it yearly. That may be too often because the incidence of finding something is not that high. But what I would tend to do is get one in the first year and the second year, and then maybe go to every 2 or 3 years after that if those were good. There is a question still whether a CTA is sufficient to see around a clip. I think the answer might be yes. Some people might say you have to do a formal angiogram to see. Certainly for the coils, once you've coiled, you have to do a catheter-based angiogram to see if there's a residual or a recurrence. But for clips, usually, unless you put a lot of clips in, you usually can see with a CTA. Okay, so please comment on the concerns regarding recurrence of aneurysms, especially in a young adult. My 27-year-old daughter recently had a clip, and a second aneurysm was found during the surgery and was also clipped. Will it be a constant worry for her lifetime? Well, I think Dr. Day is one of my partners and an excellent surgeon and part of our group. And I can tell you that the recurrence of an aneurysm from a clip is very, very low, especially if the aneurysm is completely gone. So I don't think she has to worry that much. What I would tell you is that we know that if you've had 1 or 2 aneurysms, you have about a 7% chance of developing another aneurysm somewhere else in your brain in your lifetime. So that's another reason why we do routine follow-up studies. It doesn't have to be that often, and it may not have nothing to do with your clipped aneurysm, but I have so many patients that we follow with aneurysms that we will see a new aneurysm somewhere else, and that's helpful. But the other way to look at it is that 93% of patients who've been clipped or coiled will not develop a new aneurysm in their lifetime. So it's not that common, but it is something that bears watching. I think we're going to do about 2 more questions and we'll wrap it up. This next question is, can you use coiling to repair an aneurysm once it has ruptured? And the answer is yes, absolutely yes. We use both, and depending on where and so on. I think one of the good things about our program is that we really have good expertise in both modalities. Here's a last question, and that's regarding, can a deficit resulting from a ruptured aneurysm such as mild memory loss worsen over time? And the answer is maybe, and I don't want to not answer your question, but in general, when you have a brain injury, and a brain hemorrhage from an aneurysm or a rupture is a type of injury, most patients will get better over time. They will, have them over 3 to 4 months get much better, and they will continue to get better. So if you have mild memory loss or a little trouble with calculation, or you feel like you're in a fog, there's a lot of things people will report. They can get better. As we grow older, however, we all start to notice some things. I'm not that old, but I also already noticed that I don't remember things as well as I did 10 years ago. And that's part of aging. If you had a brain aneurysm or a hemorrhage, is that gonna accelerate some? Well, that might be, but that's a different issue. And so, in general, once you recovered from a ruptured aneurysm, the course is to get better slowly, better for a long time. So thank you all for your attention, and I hope you got some good information. Thank you.